So, dear audience, welcome. As you may know, I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, European Reference Network for Rheumatological Disease. And it's my indeed great honor to welcome all of you on behalf of the ERN. Today is one of the sessions targeting sickle cell disease patients and their family. And it's about an online educational program we have shaped indeed together with the patients, because this program consists of 11 topics, one topic per webinar, and those topics have been chosen by people living with sickle cell disease by answering a survey we have conducted 1 year ago. So thank you for being with us. Today, we are going to learn about bone marrow transplant, survival, infertility, and other complications. The lecture will be provided by Dr. Subarna Chakravorty, who is a pediatric hematologist with a special expertise and interest in non-malignant hematologies. And she's also very one of the key person that collaborate with the EuroBloodNet, and she's really into patients empowerment, patients advocacy. She has done great project in peer reviews, in implying patients in peer review. Indeed, she's the national lead for the UK hemoglobinopathy peer reviews since 2018, if I'm not mistaken. So I'm very happy to pass the floor to her. Please, Subarna, the micro is yours.
Thank you, Mariangela. Can you hear me?
Perfectly, thank you.
Thank you. I would like to start by thanking Mariangela and the EuroBloodNet for this great opportunity, and also everybody here present who have taken up their valuable time to come and join this session. And I hope at the end of this session, everybody will feel that some of their questions regarding bone marrow transplants in sickle cell and thalassemia is being addressed. My main area of work has been sickle cell transplants, so I will touch that more. You know, I've done thalassemia transplants in the past as well, so we can bring about questions as they come along. I'm gonna try and see if I can share. Just a sec. I've got this. Okay. Firstly, I need to explain, and this, some people may be very, very familiar with a bone marrow transplant in this meeting today, but some people may not be. And I just like to start from the basics to tell you what really is a bone marrow transplant. So bone marrow is actually, it is a slightly gruesome picture, so apologies for that. But this is a person, and this is their skeleton. This is the pelvis, and these are the femur. So in the mostly in grown, most people above us, maybe 5 or 10 years of age, majority of the bone marrow is made in these bones in the back, in these big hip bones. And if you were to look at under the microscope, a dry, you know, a hip bone is made of inside. It's made of these kind of little caves, you know, and these caves are full of a spongy, fatty tissue. And this is the bone marrow that we all, some of us maybe like to eat if it's from an animal, or cook. And this exact place is where all these blood cells are made. The white blood cell, the red blood cells, and the platelets. White blood cells are cells that help us with our immunity. Red blood cells are the ones that help carry the oxygen, and are main blood cells that are affected in thalassemia and sickle cell anemia. And platelets are little granules that help stop us from bleeding away. So it helps clot the blood. So I think a bone marrow transplant, the way to understand it is that if you have a diseased bone marrow for whatever reason, sometimes it could be for cancer actually filling up the cave so that there is no space for the normal cells to grow, or the normal cells that are growing are actually got some defects in them, like in sickle cell disease. And you need to replace those defective or ill health, unhealthy cells and bring in someone else's bone marrow so that this other people's bone marrow can then become the patient's one, with time. So imagine if it's a garden that you are trying to plant new, or it's a field and you're trying to plant new crop for the year, you have to remove last year's remnants. So imagine that to be either a bone marrow which is full of leukemia or a bone marrow which is full of cells that perhaps are diseased. You have to remove the old cells and bring in the new cells. And the way you remove the old cells are usually through very strong treatment called chemotherapy, also shortened for chemo. And sometimes, and I'll explain that in a little bit later, is that sometimes this is so strong that it can be quite poisonous for patients. And the older you get, the harder it is to be able to tolerate all that poisonous treatment. So there are more gentle forms of treatment which are used in older patients. And I'll come to that later when we discuss some real cases, some obviously anonymous cases. So once you've removed all these old last year's crop, or once you've removed the marrow cells that are diseased, you then have an empty marrow. And then you have to plant seeds in it. And the empty marrow, then you plant the seeds, and the seeds are stem cells, basically. And the way those seeds are planted actually is not a physical planting. It's not like an operation. All you do is you transfuse, like a blood transfusion. You transfuse these seed cells back into the patient. You have to collect these seed cells from the patient, from a donor, and you give it to the patient after having cleared their bone marrow. You give it to the patient in the form of transfusion. Now, I will stop sharing because I've got a video that I want you to see. So I've got to stop share and reshare. This is a video which is a nice animation. It's in English, called Be the Match. And they did this really nice, just gives you an idea of a bone marrow transplant.
Hey there, it's Ava and Bo, here to show what happened when I had a bone marrow transplant. I was younger back then and had no idea what to expect. I know I would have liked a video that helped me understand from somebody who'd gone through one. So I'm making one. Okay, first, why did I need a bone marrow transplant? Well, I had leukemia. What is leukemia? Here, let me show you. My bone marrow, which is the spongy part inside my bones, that marrow was making unhealthy blood cells, and that made me feel sick. When there were so many unhealthy cells, there was no room for the healthy ones. So, the doctor said, time for a bone marrow transplant. A bone marrow transplant is when you get new, healthy cells in your body. Those cells come from a real person called a donor. Sometimes it's someone in your family, and sometimes it's someone you don't know. Your doctor finds someone who has the best cells just for you. I met other kids who had transplants too. My friend Jaden, he was born with sickle cell disease. Do you know why you need a transplant? It's cool if you don't. Just ask a grown-up. Jaden told me he was excited to get a transplant. However you're feeling, it's totally okay. Me? Well, I was kind of nervous. Whenever I had some big feelings, I would snuggle with my friend Bo and talk with my mom. It's always nice to have someone you can talk to when you're mad, sad, or unsure. Who will you talk to? My next video can answer questions too, like how to get ready for the hospital and what happens during transplant. Stay tuned and see you soon.
I'm also going to share the next video, which is also quite a good one. What happens when a patient has a bone marrow transplant.
it's Ava and Bo, here to tell you what happened when I got a bone marrow transplant. I made another video about what a bone marrow transplant is, if you want to go back and watch that one. Okay, so you get your bone marrow transplant at a hospital, and you stay there for a while. I was nervous. However you're feeling, it's okay. It's all new. Here's a tip. Be sure to pack your favorite, most comfortable stuff. I packed my favorite PJs, blankie, games, books, and this guy, Bo. Bo and I, we go way back. Oh, and my mom came too, but I didn't pack her. So, what are you going to bring? Okay, let's talk about when I first got to the hospital. They put a long, soft, bendy tube under my skin in my chest, a central line. The doctor gave me sleepy medicine when they put it in, so I didn't feel anything. When I woke up, it was a little sore though. I looked and what I could see was 2 tubes coming down, so instead of getting a lot of pokes, thank goodness, they put the medicine into the central line. Medicine like chemotherapy, or chemo for short. Before your transplant, you'll get chemo for a few days. Chemo is a super strong medicine that gets rid of the unhealthy cells, so there's room for your new healthy ones. Sometimes I didn't feel very good after chemo, but the nurses gave me medicine to help me feel better. Alright, so a few days after chemo, it was finally transplant day. Dun 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 dun! Look, there I am when I was younger. The transplant happened right in my hospital room. They hung the bag full of the new healthy cells from my IV pull and connected it to my central line. Body, meet new cells. I stayed at the hospital for a few more weeks to wait for my bone marrow to use the donor cells to make new healthy cells on its own. Some days I didn't feel good. I took a lot of naps, and I missed my friends. Other days, I felt better and played games with my mom, or joked with my friends on the phone. Here are some things you can do. Listen to music, watch movies, draw, read, or do a puzzle. What are your favorite things to do? Anyway, all the days were worth it because one day my doctor said, Ava, your body's making new healthy cells on its own. You can leave the hospital. Whoopee! That's the story of my bone marrow transplant. I hope it helped you learn what to expect. Remember, if you have questions, just ask a doctor, nurse, or... Meanwhile, I'm making another video about what happened after I left the hospital. Stay tuned and bye for now.
So what is a stem cell? So there is a lot of terms being used in bone marrow transplant. One of them is a stem cell. So I just want to explain what a stem cell is. A stem cell is a cell which makes a lot of specialist cells. So a stem cell can either make more of its own, so more stem cells, or it can convert into very specialized cells, such as a liver stem cell will make liver cells, a muscle stem cell will make muscle cells, a hemopoietic stem cell will make red blood cells, including red blood cells, and a nerve stem cell will make nerve cells. So when you, very early on in life, when we are all embryos, we have what's known as a pluripotent stem cells. So these cells are basically able to make all sorts of specialized stem cells. And then when we get become adults, our stem cells are mainly able to do very specialized, specific cells. So for instance, you can have a blood stem cell, also known as a hemopoietic stem cell. And in this case, the hemopoietic stem cell is what we are looking to transplant. So when I say it's a seed, that you need to take a seed cell goes back into the patient. This is what I mean. I mean, it's a hemopoietic stem cell. And these are, as you saw in the animation video from Be the Match, this stem cell is, it's just infused as a like a blood transfusion. And luckily for us, the stem cells are very attracted to the bone marrow. So it travels around the body and finds its way into the bone marrow where I remember I showed you those little cave picture. The empty cave, which has now been emptied of all the patient's own cells with the help of chemotherapy, and in certain cases with antibodies and radiation. And these empty cell caves are just waiting for these cells to come in and begin to grow. And whilst this is all happening, there will be a period of time when the patients will have no cells of their own and no cells of their donors yet, because the seed is still growing. And then once the seed embeds itself and starts making its own cells, you then start seeing these stem cells make all these different types of blood cells. So I think it's just something to remember, and maybe all of you know this anyway, but I thought it was quite a good way of introducing what actually a bone marrow transplant is. So lots of different names are used in the bone marrow transplant world, which can be very confusing. When people say HSCT or hematopoietic stem cell transplant, it means exactly the same as when they mean bone marrow transplant in sort of more colloquial terms. Although HSCT and BMT might be slightly different, depending on whether the donor seed cells, the stem cells, are collected directly from the donor bone marrow by actually literally putting a needle into the back of the donor and withdrawing the bone marrow, or whether the donor simply gives blood, which is enriched for stem cells. But in colloquial terms, these two might mean exactly the same, which is essentially a bone marrow transplant, a hematopoietic stem cell transplant. Essentially, it's the principle which I've explained to you earlier. Often people use the term allo-BMT or allogeneic bone marrow transplant. And allo-BMT only means it's from someone else rather than yourself. There's another one. If it's only exception, I suppose, is if you have an identical twin, and if you had a bone marrow transplant from them, then it would be called a syngeneic transplant. But forget that; that's very rare. You can have two types of transplants. One is allo-BMT, which is from someone else that is not you, and an auto-BMT, which is where your own cells are treated and returned to you. And again, this will be relevant because this is a type of transplant that is currently happening, although currently in trial form, but very promising, particularly when it comes to gene therapy. Then this term SIB-allo is used when the allogeneic source, the other person's source, is actually a sibling. And then sometimes the term HLA is used, HLA matching or matched sibling donor or matched sibling allo-BMT. And there's so many different terms. So HLA is also one term that you perhaps need to remember. And HLA is human leukocyte antigen, which is essentially, these are markers. These are almost like special characters that every individual has. And just like we have our very unique blood group, in the very same way, we have our very unique HLA type. And we inherit it. We inherit it just like we inherit our blood groups. We also inherit our HLA types from our parents. And it's almost very similarly inherited, just like sickle cell trait is inherited. So you get one half of your HLA type from your mother and the other half from your father. And when people in the early days, when dogs were being, animal models such as dogs and mice were being treated with other people's stem cells to see if other dogs or mice's stem cells to see if these work, that is when this special type of matching became important. That scientists worked out that you only could successfully transplant someone else's marrow into a patient or in that case, an animal, if they were matching in this HLA type. And with passage of time, and in the last 80 to 90 years, the knowledge about this has increased extremely much, such that you can really fine match patients for HLA, even if they are not your siblings. So although sibling is the ideal match, because you can get very similar, although not exactly the same as your identical twin, but it would be all very similar. If you are a fully matched, you could have very similar characteristics. And that would be a very important thing to remember in hemoglobinopathy transplants, because as you will see in the next few slides, this is what is the most important type of transplant that is being done at the moment. So I won't dwell much about this. This is a funny map. This is a map which basically is blown out of proportion from what its actual geographical area is. And that is because it's drawn in proportion to the amount of sickle patients that are born in individual countries in every year. So it's predicted up to 2050. And as you can see, that in the next 25 or so years, 25 to 27 years, the most number of patients are going to come from sub-Saharan Africa and India. And literally 2 countries in Africa and India are those 3 countries in the world will have the most number of patients. So Nigeria, DRC, and India are predicted to have the most number of new patients being born in the world with sickle cell disease. So you can see that that is a significant worldwide issue with large numbers compared to, say, in the UK, where we have approximately 15,000 people living in this country at any given time with sickle cell. And this is something, this is much, much more out of proportion compared to that. We have about 100,000 patients living in the US with sickle cell, and we have about 300 patients being born every year in England and Wales with sickle cell anemia. So the contrast is stark. And just what is the run up to the the whole transplant scenario is that before people started treating sickle cell patients seriously, which really came about in the 70s in America, with modern medicine, that is, people used to die of sickle cell very young in their childhood, which unfortunately often is the case in Africa still to this day, in many parts of Africa where there is poor access to healthcare, which of course is changing now, but that is the reality for some countries. But with time, with these interventions such as penicillin, hydroxyurea, and stem cell transplants, the survival has improved significantly, and we'll dwell on survival for a bit later. So sickle cell disease can cause a lot of problems in spleen, brain, lungs, kidneys, eyes, joints, you name it. And whereas in thalassemia, certainly in many developed countries, currently, you really only have to have transfusion-dependent thalassemia, and that would qualify you for a transplant from a sibling donor if you had one. So if you have an HLA-matched sibling donor available, then you automatically get approved for a transplant. That is not the case in sickle cell anemia, where you have to demonstrate certain points of eligibility before you are chosen to to receive a transplant. Whether that is the right decision or not, given we all know how much damage sickle cell disease can cause to patients with time, that is a matter of debate. And that debate is currently ongoing as we speak. So bone marrow transplant in sickle cell disease has been around for over 40 years. And since then, hundreds of children, even thousands of children, not quite hundreds of thousands, but at least 1,000 or 2,000 children have had their transplants. So it's not that many, but numbers are significantly increased now with countries like India coming in and doing lots of transplants over there as well. And larger studies, when they've done these long-term follow-ups, what they found is that 90 to 94% of children, so it's a very, very successful type of transplant, 90 to 94% children will have will survive a sibling donor transplant for sickle cell and for thalassemia as well. So this is a very, very successful program on all accounts. But when we look at 94% survival, we are also looking at 6% mortality. So 6%, 6 out of every 100 or 3 out of every 50 children will not survive this particular procedure. So that is something that we need to bear in mind, and something that we always bring into our discussion. Because remember, here and now, patients are well. They are not dying of something like leukemia. They are being managed with their sickle cell with whatever standard treatment that is available. So putting themselves through a transplant is a decision that has to be had jointly with the physician and the families based on all this information that is shared. And sometimes just the prospect of living with a significant disability or the risk of that disability getting worsened will very often convince parents that having a transplant and guaranteeing up to 86% overall event-free survival, which means that you are sickle disease free up to 86. So more than only 1 in 16 children out of this will actually either not survive or not have a full cure of their sickle cell condition. So in general terms, this is a very, very, very successful procedure. Say if you compare it to, say, some types of leukemia transplants in older patients. And of course, it's very, very well understood that if you can take the donor, if the donor can be your sibling, your full sibling, which has a full match, that is 100% match on the HLA type, which I just explained to you earlier, it is then that you get the best outcomes. So I'm just going to illustrate my point by just giving you some cases that we've experienced over the years. So we had a 6-year-old young lady with sickle cell anemia. She had her first sickle cell crisis at the age of 4. So but her most problems used to be infections. She didn't really have that many painful crises, but she would often come in with various infections, such as tonsil, chest infection. And of course, when you come in with chest infection, we would treat it as acute chest syndrome. So she would hemolyze, she would have like low blood count. We would end up giving her a blood transfusion, etc. Then at the age of 5, she had an abnormal test. And this is a test called transcranial Doppler. This is most or all of you will know what that means. It is essentially an ultrasound scan test that measures the risk of that child developing stroke within the next year. And we found that the risk was very high. We undertook an MRI scan of her head, and an MRI scan is a very detailed picture of what's going on inside the brain. And an MRA is a detailed picture of what's going inside the blood vessels of the brain. So we took this, and that was fortunately normal, but she did have this high risk, which was picked up on this scan. So one day, whilst we were discussing with the mother about the best way to approach this abnormal finding, she had a very high temperature. She caught a viral infection, which was one of those viruses that can cause very severe anemia. It's called parvovirus. And she was found by her mother fitting on the bathroom floor. And it was very shocking for her mother. She called for the ambulance. She was almost unconscious when the ambulance people came. She was urgently taken to our unit, where she had a repeat MRI scan. And this was 1 year since she had her last MRI scan, which was normal. Unfortunately, in the year between the 2 scans, her brain had worsened considerably. She had suffered from a stroke, and her blood vessels had also significantly damaged. We put her on blood exchange transfusions for this damage to not proceed any further. Unfortunately, we found that her younger brother, who had sickle cell trait, was actually a full HLA match. So she then ended up having a bone marrow transplant from her brother. So the options at that point was to continue regular transfusion and iron chelation. Iron chelation is the treatment that you have to give to regularly transfuse patients so that they can get rid of some of the toxic iron that builds up in their body. Or we considered whether or not we could keep transfusing her until she's 18 and then maybe give her hydroxycarbamide. These were the options that were obviously discussed with the family. But the family and us, because she was so qualifying for a transplant, we decided that we agreed that a bone marrow transplant from the sibling would be the best option. So she underwent a sibling bone marrow transplant. It was successful. Initially, it was very frequent follow-up, which was up to 2 to 3 times per week, which then gradually became less and less and less until she was only within about a year, about 6 to 9 months, she was being seen only once every 3 to 6 months, and then finally only once every year. When she was about 13, 14 years old, she ended up needing some extra hormones to make her start her periods. And in those days, we did not offer children who undergo bone marrow transplants the option of having their ovaries preserved, little girls. But that option now is available in the UK. So what option available is now is that if you're a child who hasn't yet had their periods, which means you are pre-pubertal, we would then, under the same anesthetic, under an anesthetic, basically get a specialist to come and collect a little wedge of the little ovaries that these patients have in their age. And those ovaries will have some preserved eggs that can then has the potential to grow when necessary. These eggs are then stored permanently in the freezer at -80 degrees, or higher actually, -200 degrees, sorry, beg your pardon. It's kept in liquid nitrogen, so it's very, very low temperatures, and it's kept for as long as is needed. In boys, the same thing is done. A wedge of the testis of boys who haven't achieved puberty is also collected and stored in liquid nitrogen for whenever that's needed. When these children have achieved puberty, so girls are menstruating, the boys are able to make sperm, then for boys, we just simply ask them to collect their sperm and keep it. And we keep it, of course, in the fridge and the freezer for whenever they need it. And for the girls, they are given some injections for them to produce more eggs, and then the eggs are collected through a small keyhole surgery. So girls have to undergo surgery regardless of whether they are pre or post-pubertal. For post-pubertal boys, they can simply collect some sperm. And this sperm can be collected simply by masturbation. So the reason why all this is done now is because of the risk of almost 60 to 80% risk that children might develop infertility following these transplants. So is it worth putting a child through this risk of infertility and pubertal delay, needing extra hormonal treatment? Does it work? So is the bone marrow transplant actually worth doing? And people have always asked this question, and the only answer can be found if you meticulously and over time follow these families, follow these children, and report back on them. And in fact, this is exactly what was done in this study, where they looked at up to 16 years of follow-up, up to between 1991 and 2000. They had these children between the age of 3 to 16 having stroke, and they followed these children up, up to 9 to 10 years afterwards, and there are follow-up for longer periods now. And these children were being transplanted because of stroke, because of other problems with their nervous system, because of chest problems or recurrent pain. And after their transplant, for as long as possible, they were followed up to 10, 12 years after their transplant. And essentially, they were cured of their symptoms. So they did not have painful crisis. They did not have any episodes of chest syndrome. They did not have any sequestration, splenic or hepatic. They did not need any blood transfusions. They did not have any stroke-related episodes, including overt strokes, bleeding inside the brain, etc., etc. So in other words, the purpose of doing the transplant was to prevent these symptoms from taking place, and that is effectively what was achieved by these transplants. So you could say that this is a cure. Cure has been achieved, but obviously with a cost. So I've got another patient who was diagnosed at birth with sickle cell anemia, and her first crisis was at age 4 months. She had recurrent crisis. She was very young when she had her first crisis, and then we started hydroxycarbamide when she was 9 months of age. She improved a little bit, but didn't fully improve with hydroxycarbamide. She also ended up with some hip damage only when she was 8 or 9 years of age. And then when we were giving her blood transfusions to control her symptoms, she ended up having some antibodies against her blood units. So again, it was really difficult to continue to transfuse her because we could never find the right donor units for her. So the options in this point for this child would be ask her to take hydroxycarbamide a little bit better because she's really struggling. She didn't like the size of the capsule. She didn't like the taste of the liquid. She felt very sick. Sometimes she lost hair. She was really struggling with the hydroxycarbamide at the time. So that would be an option to tell her, look, you know, this value of your life depends on you. You need to really do better. Take your hydroxycarbamide more and more. We could have started her on a red cell exchange transfusion program, although bearing in mind that it was very hard to find the right blood for her, or to refer her for a bone marrow transplant. So that's essentially what we did. She underwent a sibling bone marrow transplant and remains cured 4 years afterwards. She does not have any further problems related to her sickle cell disease. She too needed hormonal therapy to start her periods. And of course, she's not old enough yet to become a mother. So there are some other barriers to bone marrow transplant in sickle cell. One is that you might not have a sibling donor, because some of your siblings might also have sickle cell anemia themselves. Sickle cell trait is very, very well received. It's not a problem if you have a sickle cell trait. You can be a donor, but you obviously cannot be a donor if you've got sickle cell yourself. So a lot of children just don't have sibling donors who qualify. So you could look at other sources, either an unrelated transplant, so it's marrow from someone else that's not related to you. It could be from an unrelated cord blood. It could be from a mismatched unrelated bone marrow from someone else, or it could be a 50% match, which is known as a haploidentical match from a parent or a sibling. And this picture just shows you the searching for a donor. I'm going to skip a little bit quicker now because of the interest of time. We've only got 20 minutes left. This is an older patient. This is an adult age patient. She has a long history of painful crisis, poor response to hydroxycarbamide. She was very difficult to get lines into her. We could not transfuse her. When we stopped her transfusion because she wanted a break from them, she ended up with 3 chest crises in 6 months. She had lung disease and her kidneys were shot to pieces and her sibling was matched, but she was 20 years of age. In the UK, it's only in the last year really that we have started doing bone marrow transplant in adult patients under the NHS. Prior to that, funding was not available in the UK. So there were some patients who crowdsourced funding and was able to receive the transplants in our center. And some patients moved abroad to have those transplants. In America, on the other hand, they've been doing America and the Middle East, they've been doing transplants for over 10 years. And this is the kind of treatment that's used. The reason why I put this picture up, not for you to understand the names, but just to demonstrate that there is no chemotherapy as such used in this transplant, because you want a gentle form of transplant. And we use alemtuzumab, which is a special type of antibody, which is available as a sort of immunotherapy. We've heard of monoclonal antibodies a lot during COVID. This is a type of monoclonal antibody. We use a small amount of radiation treatment that is very frequently used in cancer patients, but at a much higher dose. We used a very small dose. And we used a special medicine called sirolimus, which is the one that stops your body from rejecting your donor's stem cells, and from your donor stem cells and your donor cells to fight with your own cells. So this is a very gentle type of chemotherapy. This is designed for adults because adults have lots of organ damage from 10, 20, 30, 40 years of having sickle in their bodies. So this is very well tolerated by very much older people. And very soon we are going to transplant within the UK a lady who is in her 50s. So it's going to be quite good to be able to do these for older patients as well. And this is another case. This is a 6-year-old boy with stroke whose sibling is not a match, and unrelated donor transplants can sometimes be done. And this particular child had lots and lots of problems with his head, lots of strokes, etc. And basically we were not able to find an unrelated donor. And at that point, unrelated donor transplants were actually quite toxic, and the side effects were very high. So in fact, we decided to take the donation from the parent. And again, this is a complex picture. I don't want you to necessarily try and unravel the mysteries of this picture, but essentially just to say that only 50% match is a strange type of transplant where we are saying how successful 100% matches are. And if it's any less than 100%, then it becomes a bit difficult to for a successful transplant. But this is a special way in which 50% donation transplants can be done. And the special way is really to give high-dose chemotherapy after the transplant to kill off some of the unmatched immune cells. And then the other cell that is other treatment that is used is what I mentioned in the beginning, called allogeneic. It's called gene therapy. So gene therapy is also you also have to use a form of transplant, which people may not realize, but that's what we do. You have to collect stem cells from the patient. So it's an autologous transplant as opposed to an allogeneic transplant. And the stem cells will then have to be manipulated in the laboratory one way or another to change the type of blood that the stem cells make. And then once the change is incorporated within these stem cells in the laboratory, the same cells which belong to the patient itself is returned to the patient as an infusion. And so basically the good thing about this is that other patients or other individuals are not involved in this transplant. So you don't really need a donor. Remember how I said 85% of patients, sorry, beg your pardon, let me just get rid of this. 85% of sickle cell patients do not actually have a sibling donor that is suitable to donate. Some patients might have that 50% match, but again, that comes with the side effects such as graft versus host disease. That is when you have a very immune reaction, an immune reaction to the immune cells of your donor. And the body really fights, and sometimes it wins, sometimes it loses, and there's a lot of problems. And what you don't want is chronic graft versus host disease, where there's like a very severe form of eczema if you've got graft versus host disease of the skin. But you could also have graft versus host disease of the liver, or you could have other rare graft versus host disease elsewhere. And so what you really want is no graft versus host disease. And the no graft versus host disease can happen in a gene therapy context because it's your own cells. You're not going to fight your own cells. The only problem with gene therapy related type autologous transplant is that in order to collect enough, in order to ensure that these transformed cells, the cells that have been genetically manipulated so they can return to the patient, these cells will have to need space for these cells to return to the bone marrow and start sprouting their own healthy cells. And in order to make space, we have to give chemotherapy to the patient. So again, it's kind of back to square one when it comes to chemotherapy-related problems. So the chemotherapy-related problems are the ones that I explained to you, such as, of course, in severe cases, it could be death. But as you know, that the death rates are very, very small in a transplant context. But the more important things are like immediate problems, such as hair loss, as you saw in that video, or it could be long-term problems, such as infertility, that I've already discussed. So although on one hand, you are getting rid of some problems, but on the other hand, you're not getting rid of all the problems. So I think I'm towards the end of my talk now. So it just remains to acknowledge all the patients and their families that I've worked with for so many years in sickle cell anemia and also thalassemia. I'd like to thank all my colleagues, particularly my mentor, Professor Irene Roberts, and all the other colleagues that have been named in this slide. So I'm going to I've not got much time left, so I'd really appreciate if there are any questions.
Indeed, there is one first question in the chat. I'm reading it. So I have a question. I thought only the siblings could be donors when it comes to bone marrow transplant for patients with sickle cell disease.
Yeah, I think I hope my talk has kind of explained some of that issue. So a sibling is the best choice. 100% a sibling is the best choice. You saw that in childhood, you get 94% success rate and 84 to 86% overall success rate, even years and years and years down the line. Even with the adult ones that I showed you, where no chemotherapy used, is only a small type of form of radiation and immunotherapy is used. Even then, we are now choosing siblings. So you're absolutely right, siblings is the best choice. But you can use 50% match as well, which would be either from a parent or from a cousin, or sometimes within families that marry within families. You can get lots of cousins who are 50% match. You can get siblings who obviously will be 50% match. And that type of transplant is currently being used. There are some side effects being used. And there is very soon we're going to start an adult transplant trial at King's and some other sites in the UK, where we are going to ask ourselves the question that doing a 50% match transplant in an adult patient, is it better? Will it end in better outcome for the patient compared to doing nothing, but giving the best of standard care? So yeah, so yes, sibling is the best. And unrelated transplants are now not recommended in sickle cell because the side effects are just far too much. But one option is to have family donors that are 50% match.
Thank you very much.
Hi, hello everyone.
Hi.
Hello.
Thank you for this presentation. I'm sorry, I'm home. It's a bit messy, but yeah, thank you very much. I learned a lot. I do have some questions, please, about BMT for adults, because we heard a lot about infertility for children, and now we are talking more and more about BMT for adults. And the thing is that sometimes you have adults who are between, let's say, 30 and 40 and who did not have any children, and they want to have children, and they're like hesitating between having the BMT and having children. And what do you recommend in this situation?
I think that's a very, very good question, and thank you for asking. So just to say that at the moment, the type of transplant we are offering adults is the very gentle type of transplant, which does not have chemotherapy. We use a immune monoclonal antibody, and we use radiation therapy. And the amount of radiation that is used is very small. So when we talk to the radiation experts who do this type of work, and when we looked at all the data from America and the Middle East, actually, it is not thought that this particular protocol will cause infertility, because it's so gentle that it should not cause infertility. And in fact, the case series of, I think, about 100 patients was recently published. And obviously not everybody would suddenly go off and have babies, but there were 14 successful pregnancies, both from men and women, in that transplant series out of that patient group. So I think all those patients conceived naturally, so they did not need assisted reproduction. Having said that, with every patient that goes through this transplant in our unit, where I do this work, we ensure that the families and the individual themselves, particularly the patient and their partner, get a chance to see a fertility expert who are available to work with our team. And they explain to them what it means to be infertile after a transplant, and how the risk of this particular transplant is low. Because when you hear it from the experts, it's much better. And everybody is offered the opportunity to store eggs and sperms. So of course, we don't necessarily, that doesn't necessarily mean that they will all need those eggs and sperms. They will very likely just be conceiving themselves. So my question or my advice, I guess, is that if you are putting off your transplant because you want to get your family out of the way, then that is something that you may have to think about. But equally, let that transplant not, if you want to have, you might be in a better health after you've had the transplant to actually carry the pregnancy successfully. So it is a difficult decision, but I think that the general consensus is that actually the type of transplant for adults is not that dangerous, at least this matched sibling transplant. Not so sure about the allogeneic transplant. Of course, in gene therapy, the type of autologous transplant that I mentioned at the very end, it uses a type of chemotherapy that is very, very infertility inducing. So yeah, so it just depends on exactly what type of transplant you're doing. But as I said, for most adult patients, they should not be a problem.
Thank you very much for this information. Thank you.
Okay. So thank you very much, Subarna, for having shared with us your time and expertise, and also thanks to all the participants for being here. It has been a very nice session. Thank you very much.
Thank you.
Have a nice afternoon.
Thank you. Have a good day, everyone. Thank you.
Bye-bye.